Thank you, Tanisla, for giving this opportunity to talk on intraoperative gonioscopy and microscopy settings. I'm Dr. Prasanna Venkatesh Ramesh, and my journey towards MIGS started at the World Glaucoma Congress in 2019, and this is a 4-year or a 5-year journey which I'm still learning, and I'm happy to share a few tips and tricks in the next few minutes, which is also published in IJO in the February 2023 issue. The principle of direct gonioscope, as you can see, compared to indirect gonioscope, you see the angle for what they are. The total internal reflection is broken and the angles are seen for what they are rather than the one in indirect where they get inverted. So that is bringing direct gonioscope for surgeries. Direct gonioscope was always there. If you take it, it never went out of existence. It is just that it has resurfaced. Be it the Koeppe lens, which came in 2 sizes, the Richardson-Shaffer Gonio Lens, the Barkan Goniolens, the Swan Jacob Goniolens, which we are still using, the Thrope Direct Goniolens, and the Layden Direct Goniolens. It just came back as a recent advance or resurfaced because MIGS needed it. And we have these different type of gonio lenses now. To start any MIGS procedure, direct gonioscopy is very important, where you have to visualize the angle structures and see how you are oriented in a 3-dimensional plane by taking a Sinskey hook and see if you can touch the trabecular meshwork consistently. So I started it with TVG lens, the Glaucos iPrism SX lens, and the Katena lens that you can see here, no financial disclosure. The iPrism SX gonio prism here, it's a single-use gonio prism, and without both hands, you will be seeing it that it actually stands there without using it for hands-free technique. iPrism S gonio prism, it's an anti-reflective technology and it serves its purpose very beautifully. The Volk Surgical Gonio Lens, one that I shared previously, you can see that it has a cluttering. You can see the Thornton style stabilization cluttering, which helps in docking the corneal structures better, and you can also get a movement to a certain extent. There is a Katena handheld Gonio lens. It does not have the anti-reflection coating. We have the Katena hands-free, and then the Ocular Secure Flex hands-free surgical gonio, and the recent one attached to the microscope, Oculus Gonio Ready. So there are n number of gonio lenses. What do you do after you finish your cataract, especially when you are combining it along with MIGS? Just pass your microscope, and you can see that the microscope is now being tilted 40 degrees towards me, that is the operating surgeon, and then it is sent back. And once it is sent back, what you need to do is just make sure you incline the eyepiece back to which is more comfortable for you. Just make sure you tilt it back. I recommend a pencil marking. This is before and this is after. I'm just showing it once again. Before tilt and after tilt, make sure you have a marking so that you don't need to be assistant dependent. And an inclinable binocular tubing in your microscope, as you saw in that video, is of paramount importance. You just need to incline the binocular tubing with eyepiece stooping downwards. You'll develop neck pain or musculoskeletal issues. Use an angle meter app to get your marking done. It really helps you in precision marking, whether it's a 35 degree or a 40 degree, whichever you are comfortable with. And then once the microscope settings are being taken care of, then the patient's head is tilted another 35 to 40 degree away from you. So you get a cumulative 80 degree to break the total internal reflection and view the structure directly. So this is how the scope is towards the surgeon, and the patient's head is away from the surgeon. And with this particular Thornton style stabilization ring, you can see again here, this is one of the things that I recommend for the neophytes. If possible, get your hands onto it. You get a beautiful docking mechanism and a simple HVMC. You will be able to navigate this movement, left-right movement. See, you can see here this is a blocked eye. Despite the block, it is able to move the eye left and right without causing any striations in the cornea when you put some pressure. And to start off, always take your Sinskey hook. Take your Sinskey hook, go in, touch and see the trabecular meshwork. How frequently you are able to touch it. How are you able to have the 3-dimensional spatial orientation? This serves as a long way towards your journey in MIGS. And then coming to the microscope compatibility. Of course, your microscope has to be compatible. I personally use these 3 microscopes, Backstreet, Leica and Carl Zeiss, but there are other microscopes as well. One simple observation that I noticed is any microscope produced after the year 2000, they are actually compatible. They can be manually rotatable or automated. Sometimes you may be having a knob which could be sterile, and you yourself can actually tilt your microscope. This is the algorithm that I follow: pre-operative, intraoperative and post-operative. Let us dissect the intraoperative to some bit too. So this is a recommended position for phaco that you can see to your left hand side. On the right hand side, you can see a more obtuse angle. a more obtuse angle actually in my picture as well. So with MIGS, you need to recline back and there is a more obtuse angle that you need to generate. Your left hand should be positioned well over the zygoma, and there is an apt positioning because your left hand is as critical as your right hand. You may think your right hand is your surgical hand, but your left hand support is your gonioscopy hand, and it is very, very important. And make sure you have an 100% illumination. Again, that is of paramount importance so that you don't have any loss of light or minimal loss of light. And then the corneal incision. Place your corneal incision where? Slightly anterior to the limbus so that you avoid bleeding, and also so that you'll be able to navigate inferior nasally and superior nasally. See this movement, my dear friends. This overlocking movement is very important so that you'll have a wide variety to access the trabecular meshwork, be it for excision or be it for stenting, where you have to place it 2 cloth hours apart. I use this optional technique intracamerally and Elon GB Pro. No financial disclosure again, but this is the choice of viscoelastic which works well. I had some amount of visco on top of the Elon GB Pro, and this works well for my direct gonioscopy. Foot pedal adjustments. We saw a lot about the left hand. What about the left leg? Okay, so once you have done it, take your gonio, put it and dock it. Once you have docked it, I just want to show this again. See how the blood disperses centrifugally. Now don't remove it. If you remove it, the blood will again come back into the field and it will become messy. Now what do? I just zoom in. Once I zoom in, see the animation grid on the top left, I fine focus. I fine focus the angle structures. Once I have fine focused the angle structures, I zoom out. Why do I zoom out? I zoom out because I want to identify the main incision and then take my surgical instrument, whatever MIGS I am doing, through the main incision for the successful procedure, and again I zoom in. So this particular algorithm really works well, and the left leg plays a very important role. Challenges faced? Yes. You may have reflections from scratch. If your gonio lenses are going to have scratches, you will get to have more reflections from scratch. Excessive pressure. If you're going to give more pressure with your left hand, I told you your left hand and your left leg is a very important parameter. If you're going to give more pressure, that's going to happen. A collapse of Schlimm's canal. Again, in this particular, more pressure with your left hand, Schlimm's canal is collapsing as depicted in the red arrow. Managing blood reflex. In this case, your procedure is almost done. But any excisional procedure, you may have some amount of microedema. See how I'm managing it. You just need to put a cohesive viscoelastic and see the white arrow. The blood overrides the cornea and then comes out like this. So you need to be patient in this particular maneuver. Again, similarly, during your stenting devices, when you are in the right plane, that tends to be a small amount of microedema or blood trickling. And again, you can see in this scenario where you will have to manage it. You just complete the case. But the real challenge, my dear friends, comes in cases where you need to manage blood at the inception of MIGS surgery, like a suture gap. In one of these cases where it showed when you nick with an MVR plate, blood tends to come. When you try to pass the suture at every step, the surgical field goes cloggy. You need to have a copious amount of viscoelastics and manage this scenario so that you will end up with a successful surgery, as you can see here, 360 degrees suture gap. So managing blood at every aspect of surgery is a very crucial part, my dear friends. Before beginning the procedure, have the head above the heart of the patient. It is very important to prevent this. Another very important teaching video, this is outside and this is inside. I have synced both of these videos simultaneously. So during the early stages, whenever the blood comes in between the lens and the cornea, so there is a tendency to keep making this mistake again and again. You tend to go and see again the blood will be there. You clean again, the blood will be there. Don't panic. Clean the cornea, clean the lens. You can see me here. Now I'm telling my assistant to put saline on the lens. And once the lens is also clean, the corneal area is clean. Now when you go for intraoperative direct gonioscopy, as you can see in this video, beautiful angle structures are seen. So this is something that neophytes should take a note of. Once you have practiced it, it's only a matter of time before you go for these hand-free techniques, which is very easy, my dear friends. Once you have practiced the routine direct gonioscope. Again, this is one of my hand-free technique that I perform in a live surgery. It's very much reproducible and you can really bank on it. And direct gonio with indirect gonio. So this is a different scenario which may be needed during your initial days of suture gap. So let us see one of my cases of suture gap where I was not sure during direct gonioscopy whether the suture is actually going the right plane. So what did I do? I just tilted the microscope back, tilted the patient's head back. Now I took the direct gonioscope away and went to an indirect gonioscope. Saw whether I'm going in for a false passage. Yes, suture was staying in the same plane, or rather going towards a false passage. Aborted the procedure before anything drastic could happen. So direct gonio with an indirect gonio really has its role. Make sure you use it, especially for suture gap in your early stages. And if you're looking at a good training simulation module for MIGS, we have our own surgical simulator, our novel 3D simulator. We call it the MIGS holographic 4D ophthalmic surgical simulator, which is the first of its kind, and it's a patent protected innovation of ours. You can see that you move your hands in real time, you will be able to code it in the metaverse, and our angle anatomy that we have recreated as much close to human as possible. And you can just take your stenting devices and go in and practice placing it in the right plane, not once, twice, but many times till you get your three-dimensional comfort, and now you can go into the real-time surgical scenario. We have also extensively published it, and you have many other training modules as well, like a Simulai from the New World, which has their own models. We have models from Glaucoma as well for stent placement. So when you train in these devices, when there is a mishap, like a stent which is under-implanted and it gets dropped, you can always place the second stent first, recover this, and then you can go in and place the stent later. So these are challenges that tends to happen in your practice, which you'll always be ready to navigate better. And all the data that I have talked now is also exclusively published in this chapter as well. And goniophotography, last but not least, intraoperative gonioscopy helps you in goniophotography as well. And this is a goniophotograph along with an anterior imaging that I have exclusively published this year in the Indian Journal of Ophthalmology. Summary is, start your anesthesia with peribulbar block. Take it slow, don't go topical straight away. Have your microscope tilting towards you, head tilting away from you. It's the basics, the eye magnification, the high light intensity. So these are the things. The left hand which you use for gonioscopy, the left leg that you use to adjust the foot pedal, zoom in, zoom out, fine focus in, fine focus out. And once you have done all those things, the choice of gonio lens, if you're comfortable with a particular gonio lens, go for it. I think that really matters at the end of the day. These three aspects, your anesthesia, your microscope, the patient's tilting, then the choice of gonio lenses. So make sure you cultivate your left hand and left leg. You may think it's your right hand and the right leg that is most pivoting point, but no, it's as equal as your left as well. So that, my dear friends, is more important for direct gonioscopy. So I think if I can do it, I feel my friends out there, neophytes who are aspiring to be MIGS surgeons, you too can. With that, I would like to thank Tanadala sir from the bottom of my heart once again. Thank you, sir, and Amrita ma'am for giving me this opportunity to talk on gonioscopy. Thank you.